Another facet of the subject of pharmacology is called pharmacodynamics. Pharmacodynamics, in essence, is how the drug works. This is the analysis of how drugs work. And in terms of the action of a drug, the action, the effects, the onset of action, the onset of the effect of the drug, reasonably enough, is affected by the route of administration. We know that if you give a drug IV intravenously, it's immediately in the bloodstream. You're going to get a rapid onset of action, onset of effect. We know that if you swallow it as a pill, you're going to get a slow onset of action. It's going to take a half hour before you start to get an effect. A second factor is the dosage. Haven't we pointed out that dosage, which means the same as concentration, the higher the concentration, the faster the rate of diffusion, and so you get a faster rate of onset with a higher dosage or concentration. Now, how long does the action last? So how long an effect lasts by a drug, how long that Tylenol effect lasts, how long the penicillin effect lasts, depends upon the dosage. That makes sense. You give more of the drug, it lasts longer. You give less of it, it lasts shorter. The rate of redistribution, the rate of metabolism, and the rate of excretion. So how quickly the drug redistributes to other parts of the body, how quickly it's metabolized by the liver, how quickly it's excreted by the kidneys or whatever other route it's going to be eliminated, all those affect the duration of action. Now, I'm not really asking you to memorize these things. I'm just asking you to think about it if it makes sense. So a drug that's metabolized faster will have a shorter duration of action. A drug that's metabolized more slowly will have a longer duration of action. To help us visualize this onset of action and duration of action idea, let's take a look at a graph, page B12. And on page B12, so this is just like the graph we saw just a few pages ago. This is showing that somebody took a drug orally. Maybe they swallowed a Tylenol, maybe they swallowed amoxicillin. And here you can see the absorption of the drug. So the level of the drug is rising in the bloodstream. After all, this is on the y-axis, just like last time, showing the concentration of the drug in the bloodstream. We previously saw a graph that looked just like this when we were explaining the concept called half-life. Half-life was how long does it take for the drug, level of the drug to drop from its peak level to half of that. But in this diagram, our main focus is this. In order for a drug to have an effect, in order for Tylenol to have an effect on us and alleviate our headache, we have to have a minimum amount of that drug in our bloodstream. If the level in the bloodstream becomes less than this minimum, then it has no benefit in alleviating our headache. So when we take the drug and it's being absorbed into our bloodstream, once the level in our bloodstream reaches this minimum effective level in our bloodstream, that's when we start to get an onset of action. So the onset of action begins here. The onset of action is when the level in the bloodstream reaches that minimum effective level. Now, as this drug is absorbed into our bloodstream, the level continues to rise, and then it reaches some peak level. If you took more of the drug, the peak would get higher. And then we know that as the drug is metabolized and excreted, as it's metabolized and eliminated, the level in our bloodstream starts to go down. Once the level in our bloodstream drops below that minimum effective concentration, that terminates the action. That's the end of its duration of action. So when we swallowed this drug, this Tylenol, we didn't start to get any alleviation of our headache until the level in our blood reached this much, and it provided pain relief, a relief to our headache, until the level in our bloodstream dropped below that. So this period of time between the onset of action and the termination of action is called the duration of action. This is not complicated. It may sound complicated. All we're saying is that when you take a Tylenol, you have to wait a certain amount of time before you start to get any benefit, any onset of action, right? We said 20, 30 minutes. Then it's the level in your blood's rising, and you're getting an effect, a relief from your headache. But eventually, after 2 or 3 hours, 4 hours, the effect goes away. Why did the effect go away? Because the level in your bloodstream dropped below the minimum level needed to have any benefit. So the duration of action is the time during which the level of the drug in your bloodstream was at least this level or higher, the minimum effective concentration. All right, so onset of action, duration of action, termination of action. Incidentally, let me put this in a context that you can appreciate. You know, there are a whole bunch of pain relievers. You got ibuprofen, you got Tylenol, you've got Aleve. What's the difference between them? They're all in the same class of medication. They differ in their pharmacokinetics. They differ in their duration of action, in their onset of action, how they're metabolized, how they're excreted. So you may, if a patient, for example, had liver problems, then you might want to choose one type of pain reliever over another one because maybe that one drug is excreted through the kidneys, not by the liver. Or if somebody had kidney problems, you want to give them a drug that's eliminated by the liver and not by the kidneys. So that's why there's all these different options. There are many, many members of drugs in each class or category, and they vary in their pharmacokinetics. How quickly, their onset of action, the duration of action, and how they're metabolized and how they're excreted. As far as the frequency of dosing, what does that mean? Take a look at page B12 for a moment, B12. And on the bottom of B12, all right, so we might say, what's this showing? What's the difference between taking a drug more frequently or less frequently? So let's say that you took a drug once a day. So this is labeled 24-hour dosage. So we can give a high dose of the drug once a day, and then the level falls. Right? The drug is absorbed, and then the level of drug in the bloodstream goes down. Why does it go down? Because the drug's being metabolized and excreted. Right? The drug is metabolized and excreted. So the level goes down. And then you take another pill after one day, and that raises the level, and then it goes down again. So what if you took a smaller amount of the drug more frequently? So here it's showing 8-hour dosage. So instead of taking the drug once a day, 24-hour dosage, let's consider taking the drug every 8 hours. So that's 3 times a day. Now in this case, we can take a smaller dose. So the level goes up, and the level goes down, the level goes up. And when we take it again, and the level goes down, again, it's going down because the drug is being metabolized. And then it goes up, and then it goes down. Now, if we want to maintain a certain level in the blood, if we want to maintain a certain level in the blood, which method actually helps you maintain a constant level in the blood better? Taking a large dose of a drug once a day, or taking a smaller dose frequently, more frequently? Obviously, taking a smaller dose more frequently tends to keep the amount of the drug in the bloodstream more at a constant level. And if you take it only once a day, so then you got to really raise it pretty high because we know it's going to fall all the way down towards 0. So the doctors prefer to actually have a patient take smaller doses more frequently. However, most patients prefer to take a drug once or twice a day, not 3 or 4 or 5 or 6 times a day. So even though most doctors, from a clinical perspective, would prefer to have the patient taking smaller doses more frequently, for convenience sake and for purposes of just remembering, did I take the drug, did I not take it, how frequently do I have to take it every day? Generally, most drugs they try to give take it as least frequently as possible. But that's not the best way to do things. All right, so much for that. Back where we were on page B13. Another aspect of pharmacodynamics is the mechanism of drug action. How does it work? Now, I wrote that drugs affect the physiological processes within cells. They do not produce any new actions within the body. I remember when I first learned this a long time ago, I couldn't believe it. What I was told, and what this means, is that drugs don't do anything new in your body. All they really do is speed up or slow down what's already occurring. That's why, in order to understand drugs, you need to know physiology. If you know how the body works, all that the drugs do is they speed up what's going on or slow it down. That's all. They do not create any new effect. Let me give you an example. So we have drugs called CNS stimulants. They wire you. They make you more alert. Right? Amphetamine, cocaine, they're stimulants. They speed up electrical activity in your brain. And then we have sedatives and anti-anxiety drugs that make you drowsy. They slow down electrical activity in your brain. We have drugs that stimulate the heart, that increase heart rate. We have drugs that slow down the heart rate. We have drugs that increase blood pressure. We have drugs that decrease blood pressure. All that we have drugs that increase GI motility. We have drugs that increase salivation. We have drugs that decrease salivation and GI motility. So all that the drugs are doing is just speeding up or slowing down something that's already happening. They do not create any new effect that wasn't occurring in your body already. Now you'd say, well, what about an antibiotic? Well, antibiotics really have almost no effect on our cells. What they do is they usually slow down something occurring in bacterial cells to the point where they die. But so their target is the bacteria, not us. But all it's doing is speeding up or slowing down something in either us or, in the case of bacteria.
How about chemotherapy?
Chemotherapy is slowing down cell division. Right? Chemotherapy is designed to kill cells that are dividing rapidly by slowing down their rate of cell division. And they all work by interfering with one of those 5 phases in the life cycle of a cell. They're either interfering with some process in interphase, prophase, metaphase, anaphase, or telophase. That's how they work. But it's already occurring. They're just speeding up or slowing down something that's already occurring. That's all the drugs do. Now, most drugs, the way they speed up or slow down something is generally by acting on a receptor site. Now, any drug, any chemical that acts on a receptor site is called a signal molecule or a ligand. Ligand means it binds or attaches to a receptor site. Now, on the next page, on B14, so let's show you what we mean. First off, on the top right, so this shows on the top right, on B14, it shows a cell. Now, where are the receptor sites located? The receptor sites for most hormones and neurotransmitters, which are the chemicals that our own body normally produces, for most hormones and neurotransmitters, the receptor sites are on the outer surface of the cell membrane. However, for steroid hormones, the receptor sites are inside the cell. They're inside the cell. Now, why the difference? The difference is because steroid hormones, as we've reminded you, are made from cholesterol, which is a fat. And because cholesterol and steroid hormones are very fat soluble, they can easily diffuse across that fatty membrane, so the receptor sites are inside the cell. On the other hand, for most other hormones, protein hormones, and an example of a protein hormone is insulin. Insulin and most other and neurotransmitters are generally cannot get across the cell membrane, so the receptor sites are on the outer surface. All right, fine. So the receptor sites for steroid hormones are inside the cell, and those for most other hormones and neurotransmitters are on the outer surface. Okay, so what? So here's how it works in our body. Here it shows an endocrine cell. Let's say it's a pancreas cell secreting insulin, just as an example. It secretes insulin into the bloodstream. The insulin is moving through the bloodstream, and chemicals can diffuse out of the bloodstream. Right? They can get across the capillary wall. Now here it shows two cells. This cell does not have, let's say, an insulin receptor site, but this cell does have an insulin receptor site. So therefore, insulin will not have any effect on this cell because it doesn't have a receptor site to bind to. But this cell, which has, let's say, an insulin receptor site, the insulin can attach to the insulin receptor site, activate it, and that will cause this cell to do something. So all that we do, this is occurring in our body all the time. So we have drugs. First of all, you can give somebody insulin, or we have drugs that can mimic insulin. We have drugs that can block these receptor sites. We have drugs that can activate the receptor sites and drugs that can block the receptor sites. So all we're doing is just either activating these receptor sites or blocking them to either increase the response or decrease the response. Does that make sense? All right? So this is just occurring in our body all the time, and we can just modify it. We can increase it or decrease it by either activating or blocking these receptor sites. We're going to tell you more details on that. Before we do, let's look on B15. On B15, so on B15, the drug receptor site interaction. So the drug, that was good. Yeah. So the drug binds to the receptor site. Now the tendency of the drug to bind to the receptor site is called the affinity of the drug. The word affinity is like the word of fondness, having a fondness, an affection. So the drugs vary in their fondness, their affection, their affinity for a receptor site. Some drugs have a very high affinity. That means they really want to bind. And some drugs have less affinity. So they can vary in their affinity. After the drug binds to the receptor site, it may activate it. And if it activates that receptor site, that's called intrinsic activity or efficacy. That's the capacity to cause an effect after binding. Now, I know at this moment you're thinking, I don't know what he's saying. I'm not clear. Hang in there with me. I'm going to make it clear momentarily. We have two categories of drugs, what are called agonists and blockers. Agonists are also known as mimetics. I know you're looking at my writing, you're saying, I can't even read your writing. Mimetic is M-I-M-E-T-I-C, mimetic. Mimetic means to mimic, to copy. So an agonist or a mimetic is a drug that has affinity and intrinsic activity. You'd say, whoa, what did you just talk about? A drug that wants to bind to a receptor site. That was good. That's called affinity. And then after it binds, it activates it. That's called intrinsic activity. That is called a mimetic. This is a drug that mimics the action of our own hormones or neurotransmitters. It's also known as an agonist. Okay, agonists or mimetics mean the same thing. Now, what's a blocker? What's a blocker? I wrote a blocker is a drug that has affinity but no intrinsic activity. And we're thinking, what? Imagine a drug that likes a receptor site. It binds to it, but it doesn't activate it. It just binds. So this is a drug that attaches to the receptor site and nothing happens. So that's called a blocker or antagonist. And so our first thought is, well, why the hell would we ever want to do that? Because for as long as that blocker is attached to the receptor site, it's preventing our own natural hormone or neurotransmitter from activating that. You'd say, I don't get it. Why would you want to do that? Let's use the example beta blockers. Beta blockers block adrenaline receptor sites. You see, adrenaline activates these adrenergic or adrenaline receptor sites, which speeds up our heart rate. Well, some people, we don't want their heart rate to speed up. They've got weak hearts. So we're going to give them a blocker. It's called a beta blocker. And it attaches to those adrenaline receptor sites on their heart, but it doesn't activate them. It just attaches. You'd say, well, then why did you give it? Because for as long as it's attached, the adrenaline can't activate those adrenaline receptor sites on your heart. You are blocking those adrenaline receptor sites. So therefore, even when the person is stressed and releasing a lot of adrenaline, their heart rate doesn't speed up. That's what beta blockers are used for. Because that way, their heart rate and blood pressure don't increase like most people's do during stress, because they've got weak hearts. So you're using a drug that binds to the receptor site and now blocks it and prevents the natural adrenaline in our body from activating that receptor site. So it happens to be that the blockers are even used more commonly than the agonists, than this first group. So there's a lot of blockers. Calcium ion channel blockers, beta blockers, antihistamines are really histamine receptor site blockers. So that's how a lot of these things work. So let's just summarize. We have drugs, we've talked about the tendency of a drug to bind to a receptor site. That's its fondness or affinity. And then once it binds, does it activate the receptor site or doesn't it? If it activates it, we say it has intrinsic activity. That's the capacity to cause an effect after binding. An agonist or a mimetic is a drug that attaches to the receptor site, it has affinity, and it activates it. It mimics our own natural hormones or neurotransmitters. I'm going to give you examples of all this momentarily. And what's a blocker? It's a drug that has only affinity. It binds to the receptor site, but it doesn't activate it. It just blocks it. It just attaches and blocks it. So here's some examples of what we're talking about. Amphetamines. Ever hear of amphetamines? Like benzodrine, dexedrine. How about methamphetamine or speed? All right? These are agonists at adrenergic receptor sites. You'd say, yeah, what does that mean? That means they attach and activate the adrenaline receptor sites. And they increase the effect of, as they mimic the effect of adrenaline, but it's now exaggerated because they work even more powerfully than our own adrenaline. They attach and activate these adrenaline receptor sites even more powerfully than our own adrenaline does. So now imagine, if adrenaline makes you alert, now imagine being even more alert. You'd say, I can't imagine that. Could I have some? Maybe I'll be able to imagine it then. Now, on the other hand, the drug atenolol, which goes under a brand name Tenormin, is an antagonist or blocker at the adrenergic receptor sites. So what is it doing? It's doing the opposite. It's blocking the adrenaline receptor sites. So this amphetamine is an agonist or mimetic to epinephrine or adrenaline. And atenolol is a blocker of the adrenaline receptor sites. Both amphetamine and atenolol have affinity for the receptor site. But whereas amphetamines activate the receptor site, atenolol blocks the receptor site. It does not activate it, but it prevents our own adrenaline from attaching. Example number 2, codeine. Codeine is an agonist at endorphin receptor sites. That means that it attaches and activates the endorphin receptor sites. And activating endorphin receptor sites makes us very sleepy and relaxed, among other things. On the other hand, there is, and so it works like our own endorphin neurotransmitters, but even more so. Narcan, maybe you've heard of it, Narcan is a blocker at endorphin receptor sites. So if somebody had taken heroin, which is a very powerful narcotic drug, so what they can do, they're on heroin, they're like, oh boy, I'm really relaxed, feeling good. All right? And they want to get them off this. You'd say, why do you want to get him off it? He's feeling good. But okay, he's on heroin. All right? So they give him Narcan. Narcan has even greater affinity for the endorphin receptor sites than heroin does. It attaches to the endorphin receptor sites and blocks it. So now the heroin has no effect. It literally, the Narcan had even higher affinity for the endorphin receptor sites than even heroin did. It bumped the heroin off the receptor site, and now it's blocking it. The person immediately goes into withdrawal with Narcan. The whole effect of their heroin ends right there after a single shot of Narcan. All right, so we have all these drugs that are agonists and blockers, mimetics or antagonists. Okay, now that we've been talking about those two terms, very important terms, agonists and blockers, or mimetics and antagonists, mean the same thing. When drugs attach to a receptor site and they activate them, what does activating a receptor site actually do? What does that actually do? And I wrote that activating a receptor site either opens or closes an ion channel, or it speeds up or slows down a transporter protein, or it increases or decreases enzyme activity. That's really all that activating a receptor site can do. To help us understand that, look on the previous page, B14, and we'll show you what we mean. This is the middle of page B14. This is the cell membrane of a cell. This is the cell membrane of a cell. This is the receptor site right here. There's the membrane receptor site on the surface of the cell. Everybody okay on that? Now, this is the signal molecule. You'd say, what? This is the chemical that attaches and activates the receptor site. So let's show you what can happen, whether it's with our own. It doesn't matter whether we're talking about our own hormones and neurotransmitters or drugs that mimic the effect of our own hormones and neurotransmitters. Let's give you a specific example. When acetylcholine, which is a neurotransmitter, attaches to acetylcholine receptor sites, it causes sodium ion channels to open. So acetylcholine attaching to an acetylcholine receptor site causes a sodium ion channel to open. And as you all learned from physiology, as sodium ions flow into a nerve cell or muscle cell, it generates an action potential, right? Makes that nerve cell or muscle cell become more active. So that's what our own acetylcholine does, and we have drugs that mimic the effect of acetylcholine, and we have drugs that block the acetylcholine receptor sites. Let's give you a second example, epinephrine. When epinephrine attaches to adrenaline receptor sites, it activates it, and that activates an enzyme. The name of the enzyme that's activated by epinephrine, when epinephrine activates the receptor site, it activates an enzyme. The enzyme is called adenyl cyclase. And adenyl cyclase, whether you ever heard of it or not, it's an enzyme. How would you know from its name, adenyl cyclase, that it's an enzyme? ACE. So it's an enzyme, and it forms something called cyclic AMP and stuff like that. So that's how epinephrine works. And we have drugs that mimic the effect of epinephrine and block these epinephrine receptor sites. Let's give a third example. Insulin. When insulin attaches to insulin receptor sites, and it's not really shown here, so I've just written it. When insulin activates the receptor site, it actually activates a transporter protein. So you can just write transporter protein. It's not written here on the picture. So insulin activating an insulin receptor site activates a transporter protein. What does the transporter protein do? It transports glucose into a cell. So when insulin attaches and activates an insulin receptor site on a cell, it activates a transporter protein that starts transporting sugars into the cell. And if sugars now are being transported from the bloodstream into the cell, what's happening to the amount of sugar in the bloodstream? If the sugar is being transported into the cells, it's decreasing the amount of sugar in the bloodstream. So that's what insulin does. So in these three examples that I just gave you, acetylcholine affects an ion channel, epinephrine affects an enzyme, and insulin affects a transporter protein. What did I write on B15? What did I say can happen when a receptor site is activated by a natural hormone or neurotransmitter or by a drug that mimics the action of our own hormone or neurotransmitter? It either causes an opening or closing of an ion channel, a speeding up or slowing down of a transporter protein, or an increase or decrease in an enzyme activity. That's all that our own hormones and neurotransmitters do, and that's all that a drug can do. Not only is this all that a drug can do on the cells of our body, that's all that a drug could do on a bacterial cell. You know what penicillin does to bacteria? It slows down an enzyme needed to manufacture that outer bacterial cell wall. It stops that enzyme from working. So it can't make that bacterial cell wall, so the bacteria falls apart. So that's all the drugs can do. So here we were thinking drugs do all these things, but all they're really doing is these three things, either speeding up or slowing down these three things that are already happening. That's all the drugs can do. This analysis of how drugs work is called pharmacodynamics. So, I should have shown you this picture. Let's look on B16. This will help. I should have shown this already. So what is this picture on B16? So this is the cell membrane, and this is the receptor site. Now, this is representing the natural receptor site that epinephrine or adrenaline binds to. So when epinephrine or adrenaline attaches to this adrenaline receptor sites, it causes an effect. Okay, it actually causes an enzyme, speeds up an enzyme. Now, what is amphetamine? Amphetamine is an agonist or a mimetic. What did we say an agonist or mimetic is? It's a drug that similarly attaches to a receptor site and activates it. Now, here's the big difference between amphetamine and epinephrine. Our body makes epinephrine, adrenaline, and we have an enzyme designed to break down epinephrine or adrenaline. But the enzyme that's designed to break down epinephrine wasn't designed to break down amphetamines. So if you give amphetamine, it activates those epinephrine receptor sites, but it's going to take hours for the enzyme to break amphetamine down. The same enzyme that breaks down epinephrine in minutes will take hours to break down amphetamine. So let's say that you wanted to stimulate somebody's brain. Okay, you want to increase CNS alertness. If you give them adrenaline, a single shot of adrenaline, it'll increase electrical activity in their brain for a few minutes until the enzyme in our body breaks it down. But if you give them a single injection of amphetamine into their bloodstream, it'll take hours for that same enzyme to break down this strange chemical that's not normal in our body. So why give amphetamine rather than epinephrine? We get a longer duration of action. This is called an agonist or a mimetic. It mimics the action of our own chemicals, but it gives us a longer duration of action. Now, what's a blocker? We mentioned atenolol or tenormin. It's an antagonist, a blocker. It attaches to the epinephrine receptor site. It does not activate it. But for as long as it's attached, our own epinephrine cannot activate it. It is blocking our epinephrine receptor sites. So we basically have drugs that are agonists and blockers, drugs that mimic our own natural hormones and neurotransmitters, and drugs that block our own hormones and neurotransmitters. Does everybody kind of follow this? This is the idea of receptor sites. On B17, there are a few drugs, not many, that do not act on specific receptor sites. And the two, really, I can only think of 2 or 3 types of drugs that don't act on receptor sites. They don't activate them, they don't block them, they have nothing to do with receptor sites. And they include antiseptics. Antiseptics just kill cells. They are not activating or blocking receptor sites, they're just killing cells. An example is rubbing alcohol. Another drug that doesn't affect receptor sites is nitrous oxide and other general anesthetics. General anesthetics do not act on receptor sites. They just temporarily interfere with the conduction of nerve impulses. They temporarily interfere with the conduction of nerve impulses, but not by acting or blocking on receptor sites. Incidentally, that's general anesthetics. I might just say as a side note that local anesthetics like lidocaine do act on specific receptor sites. They actually have the effect of temporarily blocking the sodium ion channels in nerve fibers. And by blocking the sodium ion channels, that prevents the entry of sodium ions into a nerve fiber, and that's how they block the conduction of impulses. Let's just, before we get into let's do dose response. Okay, so dose response relationship. Dose response relationship or dose effect, very simple idea. As the dose increases, as you increase and give a patient more and more and more of a drug, you get more and more of a response. However, all drugs reach a maximum response. In other words, if you took Tylenol, you take 1 Tylenol, you get a certain amount of pain relief. Take 2, you get a little bit more. Take 3, you get a little bit more. But at a certain point, if you increase your Tylenol anymore beyond a certain point, you don't get any greater pain relief. So all drugs exhibit some maximum of effect. So the maximum of action of a drug has to do with its intrinsic activity or efficacy. That's the capacity to cause an effect after binding. Now, potency is this concept that refers to the amount of drug needed to produce an effect. And I think the best way that I'm trying to make a distinction between the word efficacy and potency, and let me try to make a distinction of these two terms. And I know you've heard of potency, and you might have heard the word efficacy. I've used it today. Of these two terms, this one is the more important, efficacy. To help you understand this, let's look on the bottom of the previous page, B16. Okay, this is the bottom of B16. and it shows a graph, and typically what it shows on the x-axis is the dose. It is very common when plotting the dose of a drug that they don't plot it by simple numerically, but they plot it logarithmically or exponentially. And you might say, what do you mean? Well, in other words, here it's showing 10 milligrams, and here it's showing 60 milligrams, and here it's 600 milligrams. They commonly like to do it 10, 100, 1,000, 10,000. They kind of plot it exponentially or logarithmically. On the y-axis, this is showing the degree of pain relief using 4 different pain relievers. So, first thing I want to point out is the concept of efficacy, right? And it shows efficacy is how high up on this pain relief you are. Now, according to this, the drug that provides the greatest amount of pain relief is morphine. Can everybody see it's got a graph line? And this is where its maximum effect in pain relief is reached, up here. This is its maximum efficacy or effect. Now, in contrast, look at codeine. This is codeine. And codeine, this is its maximum effect. And then, way over here is aspirin. This is aspirin's maximum effect in pain relief. So we say that aspirin provides mild pain relief. Aspirin provides a mild degree of pain relief. Codeine will provide a moderate degree of pain relief. And morphine provides strong pain relief. Does everybody see that? So I think we can all appreciate that taking aspirin, you're not going to get as much pain relief as taking morphine. Is that fair to say? It doesn't matter how much aspirin we give you, you will never get the same maximum pain relief with aspirin as you will with morphine. Morphine has a greater efficacy. The greater the amount of effect, the greater efficacy. The word efficacy sounds like effect. You get a greater maximum effect. All right, so much for that. Now, what is potency? Potency is actually shown going in this direction. This is efficacy, is the degree of pain relief. Potency is the dose. You'd say, well, like, what do you mean? Look at meperidine. You'd say, what is meperidine? Meperidine is the generic name for Demerol. Many of you have heard of Demerol. All right, now, can everybody see that Demerol provides the same maximal pain relief that morphine does? You'd say, how do you figure? Can you see that they both, Demerol, meperidine, and morphine, reach this level of strong pain relief? Does everybody see that? Now, what dose do you need to get maximum pain relief with morphine? 10 milligrams. Everybody see that? What dose do you need to get maximum pain relief with Demerol? About 50 milligrams. So in other words, if you give 10 milligrams of morphine, you'll get this maximum strong pain relief. Or if you give 50 milligrams of meperidine or Demerol, you get maximum strong pain relief. So, which one do you need to use less of to get the same pain relief? Morphine. So we would say morphine is more potent. It's more potent. It means you don't need as much of it to get that same maximum degree of pain relief. Now, frankly, in my mind, potency is irrelevant. I don't really care when I take my medication. I don't care if I'm taking 10 milligrams or 50 milligrams. If it provides me with the same maximum strong pain relief, I don't care whether I need 10 milligrams of morphine or 50 milligrams of Demerol. I just want to get that really strong pain relief. Does everybody follow that? So, in my mind, potency is not very important. What is important is efficacy, the maximum effect. both Demerol and morphine are equally effective. They are equally efficacious. They both provide an equal level of strong pain relief. Now, what about codeine? That only provides moderate pain relief. And what about aspirin? Mild pain relief. Efficacy is the important concept. That's the maximum effect that you can get. Incidentally, if I wanted to have moderate pain relief, let's say all I needed was moderate pain relief, I could take 60 milligrams of codeine, or I could take probably 30 milligrams of Demerol, or I could take 5 milligrams of morphine and still get moderate pain relief. In other words, while morphine and Demerol will provide a much higher degree of pain relief, I could just take less of it and just give me moderate levels of pain relief. The point is, again, with any drug, you take more and more, you get more and more effect, but at a certain point it maxes out. It maxes out. Taking more beyond a certain amount, where you get maximum effect, you don't get any greater therapeutic benefit. What you get is only more side effects. So there's no benefit in taking 20 Tylenols. If you need 20 Tylenols, you don't need Tylenol. You need something stronger than Tylenol. Because Tylenol just won't give you that pain relief. All right, let's go back to on page B17. On B17, another very important concept is biological variation in response. So we can all appreciate in this class that if we all had equal headaches, and we might say, yes, this class is giving me a headache, some of us, if we all took Tylenol, we all took whatever, the same pain medication, some of us would need more and some of us might need less because we're all different. There is biological variation in us. And this is true for everything as far as how drugs work. So this is simply the concept of biological variation in response. Let's actually look at a picture to help us see this. It's on the next page, B18. On the top of B18, so as you know, most things that we can analyze about the body, the human body, exhibits what we call a bell-shaped curve, or Gaussian distribution. And we could use this to describe height, right? Most people are a certain height. They're in the middle of this curve. We've got some people who are really short. We've got some people who are really tall. They're at the farthest edges, at the extreme ends of this general of most people. All right, we could talk about height, we could talk about weight, we could talk about IQ, we could talk about all these different characteristics. We can also apply this in terms of how drugs work. Most people respond more or less similarly to a drug, but there's always some people who are hyperreactive and those who are hyporeactive. You give some people the pain reliever Tylenol, and it's like they're hyporeactive, right over here. You give, two won't do anything. 3 won't do anything. You got to give them 4 to get any kind of pain relief. They're at the far edges of being underreactive to that medication. And then you've got some people where if you give them 2 Tylenols, they're on the bed. So is anybody in this class really sensitive to something like Tylenol? All right, where some people, have you ever met anybody where I know some people, they say they take a Tylenol, makes them go to sleep. Boy, it doesn't make me to go to sleep. But some people, it just says it knocks them out. They're at the hyperreactive end. So this is basically true for everybody. Now, since we know that there is variation, biological variation, differences in sensitivity to drugs. So when you read on a package of a medication, on Tylenol, and it says take 1 to 2 Tylenols, who's that for? Are they talking to the person who's hyperreactive? No. Are they talking to the person who's hyporeactive? No. They are talking to the majority of people, and that number, that dose, that affects the greatest number of people, where it's neither too much nor too little of the drug, that is called the ED50. ED50 stands for the effective dose in 50% of the population, the ED50. So anytime you look up a drug and it tells you the dose, that is the appropriate dose for 50% of the population. That's this middle 50%. But some people are going to be overreactive and some are going to be underreactive. So all we're doing is try to recommend or give the dose that is most beneficial for the middle 50% of the population. That is called the effective dose for 50%. So back on the previous page, B17. What is the ED50? That is the therapeutically effective dose for 50% of the patients. Now, this gets a little bit more complicated. You might have heard the concept in a physiology class that when you look up, when you're told in a physiology or a medical book, you know, what a normal heart rate is or what a normal blood pressure is, that's the normal heart rate or normal blood pressure for a young adult male. Was anyone ever told that? I know if you had me, you were told that. In other words, because, for example, the normal lung volume of a guy, of a 20-year-old guy, is 6 liters. A guy's lungs can hold about 6 liters of air. The normal lung volume for the average female is 4 liters. That's a difference of 2 liters, a difference in lung volume. So when you look up in a medical book what's normal, they always traditionally tell you what's normal for young adult males weighing 70 kilograms. That's called your reference man, your reference person. If you're dealing with somebody who's not a young adult guy weighing 70 kilograms, then you've got to adjust the dose. You have to adjust everything. So when we talked about this effective dose in 50% of the population, we're talking about the effective dose for the 50% of the population of young adult guys weighing 70 kilograms. It's not actually the dose that's effective in 50% of everybody, but 50% of those weighing 70 kilograms are young adult guys. So because of this, when you're dealing with somebody who's not a young adult man weighing 70 kilograms, you have to adjust dosages. There are many formulas to adjust drug dose. One of the most common formulas, the only one I'm going to ask you to know, is called Clark's rule. Clark's rule is where you adjust the dosage based on weight. There are other formulas that adjust the dose based on age, based on gender, based on even surface area, which is actually the most accurate. All right, so let's show you how this works. If you look up codeine, you would see that the recommended dose for codeine, the ED50 for codeine, the effective dose in 50%, not of the whole population, but 50% of young adult men weighing 70 kilograms, about 150 pounds, is 60 milligrams. So if you look up codeine, it will say 60 milligrams is the recommended dose. But what if you're dealing with a child, just let's say as an example, and let's say you're dealing with a child who, a child weighs, and let's say they're 50 pounds. So if you're dealing with somebody who weighs 50 pounds, if they tell you that the normal dose for codeine is 60 milligrams, so we've got to adjust this dose for a person who weighs 50 pounds. So how does this work? We take their weight, which in this case is 50 pounds. We multiply it times the adult dose. What's the adult dose? 60 milligrams. And we divide it by 150. Why 150? Because this normal adult weighs 150 pounds. And that's why I say it was for an adult guy. Right? Is the way this was originally set up. So Now so what's the dose that a 50-pound individual should be given? Obviously the pound units are going to cancel out. The dose is going to be in milligrams. And if we multiply 50 times 60 and divide it by 150, and we can multiply it out. Incidentally, 50 divided by 150 is like 15 over 15, which is 1/3. And 1/3 of 60 is 20 milligrams. All right, so whether you multiply it out or you simplify it. So in other words, if you look up a drug and it says 60 milligrams, and you're dealing with a 50-pound person, you give them 20 milligrams. You don't give them the adult dose. That makes sense, right? But there are many other factors that we should take into account. Since the normal dosages that they give are for young adult men weighing 154 pounds, 70 kilograms, you should also take into account other factors, including their age. Keep in mind that, and we talked about this last time, children and the elderly are more sensitive to drugs. They are more sensitive to drugs. We had learned last time that children and old people break down drugs. They metabolize drugs more slowly than 20-year-olds. So if you're dealing with a child or you're dealing with an 80-year-old, you give them a lower dose of the drug than you give than the ED50 calls for. The gender, whether they're male or female, who's more affected by drugs? Who's more sensitive in general, males or females? Females. Because females also metabolize or break down drugs more slowly than guys do. So females are more sensitive. Why do females in general break down drugs more slowly than guys? Who's got a slower metabolic rate? Females. Their metabolic rate is slower, so the rate of all the biochemical reactions occur at a slower rate than in guys. Incidentally, a side note, I sometimes point out when I teach biology and physiology, so, understandably, women say, they say, it's not fair, guys have a faster metabolism, they can eat more food every day than women can, they jump, in general, they jump higher, they run faster, it's not fair. There is a cost to the guy in having this faster metabolic rate. What's that cost? He dies 7 to 9 years earlier. That's the cost. So that faster metabolism, if you slow the guy's metabolism down, you'll give him 7 or 9 more years of life. All right? If you want to have a metabolic rate like a guy, you'll lose 7 to 9 years of life. So there's a cost to that. So we have to look. Now, on page B19, incidentally, on B18, if you look on B18, you'll notice there are a whole bunch of different formulas. I'm not asking you to know these, but there are a whole bunch of different ways of adjusting the dose of a drug. The only one I mentioned was Clark's rule. But there's Freed's rule, Young's rule, Cowling's rule, and the surface area rule is probably the most accurate. That's because surface area takes into account not only the weight, but the height. Takes into account everything. And incidentally, speaking of weight and height, if you only adjust based on weight, which is Clark's rule, what if you happen to be dealing with a child who happens to weigh a lot? Right? Aren't there some kind of obese kids nowadays? Mm-hmm. So maybe you've got a kid who weighs 150 pounds, but he's only 11 years old. So if you only adjust it by weight, you're going to give him an adult dose. But he's only 11. So maybe he really shouldn't. So you really need to adjust really using other criteria than just weight alone. So that's... Now, on page B19, some other criteria is pre-existing pathologic states. How does hypothyroidism or hyperthyroidism affect somebody's metabolic rate? How does, if somebody's hypothyroid, how's their metabolic rate? Slower. So they need a lower dose because they break down the drug at a slower rate than normal. On the other hand, if somebody has hyperthyroidism, so their metabolic rate is faster than normal, and so they break down drugs at a faster rate, they may need a higher dose. Anytime you're dealing with patients with thyroid problems, you have to adjust drug dosages. Another factor that we should mention is psychological factors and something called a placebo effect. So what's a placebo effect? I know you all know this, so I'll just kind of give you an example. Let's imagine I was wearing a white coat with my name monogrammed on it, and I've got a stethoscope wrapped around my neck. Let's imagine you don't know me, right? And I walk into the room and you're thinking, wow, I've got a really bad headache. And I say, I've got this white coat, my name's monogrammed, I got a stethoscope, and I say, I've got something that'll really going to help you. And I hand you a couple of pills, right? And we'll assume that you can trust me to take these, okay? And a half hour later I say, are you feeling any better? Did that help? 30% of you, even if I gave you pills containing starch, 30% of you are going to say, I feel better. I feel, thanks, that helped a lot. That's the power of the mind and suggestion. And incidentally, we shouldn't discount it. We haven't done fraud, per se. We're simply saying that you can actually use that to your advantage. Because the power of the mind, again, especially for things like pain, so much of pain is, what's in our mind. And if you think that something is really going to help you, about 30% of the people are going to say, boy, that really helped. Right? That's called the placebo effect. Stress and emotional state can affect how we affect certain conditions and therefore affect the dose of a drug we need. These are some conditions that are highly affected by your emotional state. Asthma. If anybody has asthma in the class or knows of people with asthma, kids with asthma, it is often brought on by, they get excited, they get anxious, they get stressed, and then they have an asthma attack. So it is greatly affected by their emotional state. Arthritis. Arthritis is associated with pain in the joints. It is greatly affected by one's emotional state and stress. Headaches. Obviously, many headaches are brought on by anxiety and stress. If anybody in the class is prone to migraines, migraines are often brought on by stress. That happens. High blood pressure, because when you're stressed, you release adrenaline, and adrenaline does what to your blood pressure? It raises it. A sexual response. Obviously, sexual response greatly affected by one's emotional state. Acid reflux is affected by emotional state and stress. Menstrual disorders, greatly affected by emotional state. Muscle spasms, and of course insomnia. Whether you can get a good night of sleep or not depends upon how stressed you are and your level of anxiety. So emotions and stress do affect our conditions. I want to emphasize something. I didn't say that stress is the cause of these. I'm just saying that stress affects these. Some people who have asthma, stress doesn't determine whether you get asthma or not. Some people get stressed and they never have asthma. But if somebody has asthma, stress can trigger it. It can bring it on. Stress is not the cause of high blood pressure. But if you have high blood pressure, stress makes it worse. That's all I'm saying. I didn't say it's the cause, the underlying cause, but it can make things worse. Another thing that I mentioned last class meeting is drug tolerance. I actually mentioned this on Friday. Drug tolerance, which is clinically called tachyphylaxis, is this idea that when you repeatedly take a drug every day, you get less and less effect or response. And the example that I gave you, on Friday was coffee and the caffeine. So when you take coffee all the time, you get less and less stimulation. It doesn't wake you up as much as it used to. So this is true with many, many medications. It's true with cocaine. It's true with heroin, that when people take these drugs, they need more and more and more of it to get the same benefit or same effect. Now, why is there this decrease in effect when you take it over and over? And as I wrote, it's due to cellular and biochemical adaptation to the drug. More precisely, when you repeatedly take a drug all the time, your liver manufactures more enzymes. And therefore, you break down that drug at a faster rate. So all of us who are in the habit of having coffee every day, so your liver produces more enzymes that break down caffeine. So you break down caffeine at a faster rate. As we said last time, if you stop drinking your coffee for a couple of weeks, even a week, the enzyme levels in your liver will go down, and therefore, when you drink that coffee after not having it for a week, you're going to feel it a lot better. The last item that can necessitate adjusting the dose of the drug, complicated subject, is drug-drug interactions. And we wrote that taking more than one drug at the same time might require that you increase the dose, or you might actually have to decrease the dose. And it depends on what the other actions of that other drug are. Let me give you a couple of examples of what I mean. So let's imagine that somebody is, they've got an allergy, and they're taking an antihistamine on a regular basis. There are lots of antihistamines. Benadryl is a common one that's available over the counter. We mentioned Allegra, Clarinex, Claritin. These are prescription antihistamines. So they're taking an antihistamine. And then one evening, let's say the person goes out for dinner and has several glasses of wine. Now, what are we worried about here? Drowsiness. Because antihistamines have a side effect of causing sedation or drowsiness. Alcohol causes sedation or drowsiness. And so when you start to add, and so I gave the example of wine, which isn't even a prescription drug or anything like that. Instead of wine, what if I had said, if I wanted to talk about a drug, what if I said the person was taking, let's say they were going to take something to help them sleep, even though they're taking an antihistamine for their allergy. So there are many medications they might take to help them sleep. What's the common one that people take when they're going to take an airplane flight? Dramamine, or how about Ambien? Actually, a registered brand name. All right, so the combination of these two, and then if they were to take the wine as well, these all have additive effects. And there have been people who've taken a couple of medications that both cause central nervous system or CNS depression. They cause them to get drowsy. They had some wine, and guess what? They're now in a coma because they just never wake up. Another example, besides drugs that cause sedation where we run into a problem, let's imagine that somebody is regularly taking, let's say they're regularly taking Plavix. Plavix is used for what purpose? Anybody know? Plavix is used to reduce blood clotting. It's an anticoagulant. It affects the blood clotting mechanism similarly to aspirin. So let's say they're taking this anticoagulant. They have been identified as being at increased risk of having blood clots. Maybe they've had a small stroke or a small heart attack, so they want to reduce this tendency to form a thrombosis. And they've got a headache. And so for their headache, they take some Excedrin. And in Excedrin, there is aspirin. What are we worried about here? massive bleeding. Because aspirin also is an anticoagulant, is used to reduce blood clotting. So when you start adding these things together, then you have to worry about these additive effects. The most common drug-drug interactions are actually shown on a chart on page Z9. So if you go all the way to the very end of the lecture outline, these are the 10 most common drug-drug interactions. And we're going to see that many of them specifically involve blood clotting and preventing blood clotting. Warfarin, which you may have heard of, also known as Coumadin. So very similar to the example I just gave you, if somebody is regularly taking Coumadin as an anticoagulant, and then they take an NSAID, a non-steroidal anti-inflammatory drug, NSAIDs are like aspirin or Celebrex or Aleve, and they also have an anticoagulant effect. So we get an additive action.